Hi, good afternoon, everybody. I'm Winnie from Group Clinical Education here at NHG, and welcome to today's Humanity at the Heart of Healthcare seminar series. And that's a series that's organized by my team, Education Research. Now, the H3 series for short aims to highlight issues at the intersections of social sciences, humanities, and healthcare. And today we're happy to bring to you the work of two very familiar faces, especially for webinar participants in Woodlands Health. Ms. Roxanne Chu is a senior art therapist in the Department of Allied Health in WH. Roxanne works with adults in palliative, psychiatric, as well as geriatric care settings. And she's also interested in promoting self-care for clinicians through art. Roxanne's background is quite diverse in nursing, psychology, and art therapy as well. And she uses workshops, qualitative research to underscore her commitment to advancing art therapy. Now, Dr. Lim Wen-Pei here is Senior Consultant Medical Psychiatry in WH, and Wen-Pei is a very familiar face to all of us at education, being the ADIO, so that's Associate Designated Institutional Official, right, in NHG residency. Wen-Pei is also involved in undergrad education as the Assistant Principal Lead for Psychiatry in 𝐘𝐨𝐿 Medicine. So welcome, both of you. Both Roxanne and Wen-Pei were co-first authors in a research article that was published this year in the journal Palliative Medicine. And they're here today to share about their study and also to talk about using reflective journaling, not only as a source of data for qualitative research, but also as a way of developing an understanding of clinical experiences and compassionate care strategies. Now, for our participants, some housekeeping matters. We'll be using Slido, the platform for your questions and comments, which Wen-Pei and Roxanne will be fielding near the end of the webinar. So we have about 15 minutes reserved at the end, about 1:45 onwards for your questions. So do stay tuned for that, and we will have a QR code for you to scan and to enter your questions, right? And as usual, do stay on till the end at 2 o'clock to give us your feedback about the webinar and to register your interest for future webinars. So with that, I'd like to leave you in the very capable hands of our speakers for today, Roxanne and Wen-Pei. Over to y'all.
Thank you, Winnie, for the wonderful introduction. Good afternoon, everyone. It is really nice to be in the company of friends. As I look at the participant list today, I see many familiar names from our partners all across NHG. Tan Tock Seng, Yishun Health, Woodlands Health Campus, NCID, NCC, and I see some friends from our community partners, Sing Health and NUHS as well, and beyond. So welcome and thank you for joining us today. Roxanne and I are really pleased to share this piece of work, small, humble project, but with the blessings and the help of our supporters, friends, colleagues, and mentors, we managed to get this published in Palliative Medicine recently, and we're really pleased to share this with you. Now, today you're going to hear about stories. and you're going to hear about stories from people who wear multiple hats. I'm going to take Roxanne, if I may, as an example, who wore multiple hats throughout her life, starting off her career as a nurse, who went on to work in an ICU setting, and then decided to go into research, working in maternal infant health. And then she went on to be an art therapist, working in end-of-life care settings. And then through this piece of work, she and myself had to question, when are we the researchers and when are we the subject of the research data? And when are we viewing things through our own lens? And when are we assuming the lens of the patient? So the both of us are really excited to be able to share this piece of work with you today, titled Psychological Health in Palliative Care, where we conducted a thematic analysis of our clinical reflexive journals, including art journaling and response art. And we hope to be able to take you through this 1 hour session of sharing of this years-long project. So over to you, Roxanne.
Thank you, Phei, for the wonderful introduction. I'm so glad to be able to present this piece of work. And this piece of work will be also a tribute to our patients that we have seen. And today I'll be telling a bit of storytelling, so you will not be so bored, and hopefully this would ignite some interest in qualitative research as well. Okay, let me dive in. Okay, so this is Phei. Does she look like the picture, the video that is showing her right now? Yeah, it all started from a small curious question that she had. From what we know, patients experiencing end of life often develop psychological issues as they deteriorate, and clinicians may or may not be equipped to manage these psychological needs that the patient when they're in the dying phase. So this kind of sparked an idea in Phei in trying to learn more about psychological health in end of life. But before that, she kind of needed a partner in crime. So she connected with me and sold her idea to me. And of course, I said yes, because I have a lot of interest in learning more about this topic as well. Before we went on to learn more about to think about our research questions, Phei started to share more about reflexive journaling. She shared that this was often used in clinical education. And she shared that, how reflexive journaling allow one to record the personal experiences, their decisions, and feelings arising from observations made in the clinical setting, research processes, or learning activities. And this will help a person to develop professionally and to also help to contain difficult thoughts and emotions. And when she shared this with me, I was like, hey, this is really similar to what an art therapist does. We do response art as well, and we create art in response to a situation or event. The art may be quick and it may not be beautiful, but this is where imagery expressing inner feelings may be used to make cognitive sense of the images. And we also use this to do this as a reflective approach that can facilitate our self-dialogue and understanding the relationships as well. So we know there's a shortage of literature using lived experiences as a source of knowledge and trying to understand what psychological health means in the context of end of life. So Phei and I, we just hopped onto this boat and we journeyed together and collaborated together and in the search of understanding psychological health in palliative care. So the method that we used was to look at our reflective and visual journals as first authors, and also to apply practice wisdom when we were looking at our journals to use knowledge as well. And we were guided by 3 research questions. The first one, what has my experience taught me about psychological health in palliative care? Number 2, how do my patients experience psychological health at the end of life? And number 3, how does my work as a clinician influence the provision of psychological health in palliative care? So our design reflects a constructivist belief that reality perception is constructed from individual, social, and historical contexts. And we also adopted an autobiographical approach to describe and to analyze personal experiences via storytelling. So Phei and I, we were first authors. In other people's journals of practice wisdom, usually it is done by solo clinicians. However, because we have each other, we were able to review each other's journals, and we were able to look at each other's journal, and it served as an inter-rater process as well. On top of that, we do have a second author, and this second author was actually a mentor to Phei during her HNBP time. And Claire acted, who is a music therapist, acted as a mentor to us as well. So we were constantly, writing to her online and sharing with her what our progress was during our study. So to share more about data collection, we were actually on a 6-month journey of just journaling process. And we detailed 107 encounters with our patients in 2019. So this situation included the first one, patient encounters, or patient family members or their loved ones, or clinical conversations. And during the way that we collected, the method that we used was either reflexive journal writing, or either we will add in response art making where appropriate. And after art making, we would do further reflection writing after response art to get more perspective in the same journal entry. So the way that we've written our journal was based on 𝐸's reflective cycle. So we talk about, what happened during our encounter with the patient, what we were feeling, the good and bad experience as we evaluate the situation, and what can we make sense out of this situation as we analyze, and what else we could have done as we conclude, and if possible, we even came up with our action plan as well. So our data was collected, guided by the selected grounded techniques to produce themes. So Phei and I, first, we actually coded our journal independently. So we generate the whole list of codes, and this took a huge amount of time. And after that, we exchanged each other's journals, and we read each other's codes as well. And then we sit down together, we were, debating a lot. We had a lot of disagreements. We debate and refine until we came to an agreement before we move on. And then we started to compare and contrast our codes together. And after, we started to group them into research-related sub-themes, and we started to repeat the whole process until we get our main themes. Then that's when we had our second mentor, our second author, to help us to review and to refine themes until we came up with our final results. It was a very long and tedious process, but we did it. So are there any ethical issues when we look at our own journal? So the SRB actually exempted us because our study did not involve any direct study of human subjects. But because Phei and I were not just a researcher, but we were also clinicians on the roll. So in order to make sure that our roles were not compromised, we actually came together to regularly discuss any related issues of our study. And we started to realize that when we were journaling at the same time, this provided a space for metacognitive awareness to separate, the difficulties between being a clinician and being a researcher as well. And the third thing we did was actually to seek for clinical supervision to make sure that we are very clear with our roles. Okay, so now we'll be moving on to the results section. Okay, so in total, right, we have 107 clinical encounters, 32,000 more words, 36 artworks, and 905 codes were collated. It's a lot of codes. So as what you can see in this diagram over here, in this table, all these codes were under sub-themes that we placed them. And this is just a small subset of codes that you are seeing. So you can imagine we had a lot of themes and codes together, many pages of them. After debating, cleaning up, we managed to come into the 67 sub-themes, and it was still a lot. We had to sit down and discuss, debate, and refine it. And finally, we came to our broader themes that we, it was more or less fixed. However, because Phei and I, we had kind of, data blindness to our data. So we had to seek for our mentor where we refine again, review again. And finally, this is our cleanup results. So I would like to invite the audience to, take a look at these results, kind of absorb it, and kind of, remember what is written here, because this would be very useful when you actually nurse a client in palliative care. So what makes psychological health in palliative care? We look at two main aspects. The first aspect is actually patient attributes. And under patient attributes, we have skills to navigate death, retaining personhood, resilience, and having very good relationships and connections. And we look under clinical care. We look at holistic clinical competencies, the capacity for reflective practice, and integrated care and support systems. So Wen Pei and I will be presenting the next part together, and we'll be going through each aspect together. So how this would be presented would be, if Wen Pei actually wrote the code or did the artwork, she would come in as the first person to present that. And if I'm the one that did so, I would be the one presenting my part. Okay, so we'll look under patient attributes first. For the first aspect, skills to navigate death, we talk about dying is actually a period of profound change, and how accepting and adapting to these changes is essential for a patient's psychological health.
When we broached the possibility of physical rehabilitation, he expressed reservations, as rehab would mean new situations he has to cope with. His remark, mentally coping well with cancer is more important than rehabilitation, really struck me. When I thought about this patient, I thought about how we would often advocate for patients to proceed with recommended treatments, but what we view as important may not be viewed the same by the patient.
So I actually had this patient who shared with me how death was a difficult topic to talk about, let alone accepting death. As seen in the artwork here, the girl is covering her mouth. It's a dark day, it's snowing heavily, and this showcases actually how painful and challenging it is just to navigate death. We also learned that while dying has a universal theme of loss, the way in which patients experience these losses varies. The patient's ability to negotiate these losses become critical in ensuring psychological health as well. And I quote, "After art making, she started to cry and shared that she was feeling very sad due to difficulty accepting her loss. She felt lonely, as shown in the image where she was alone in a boat." So I remember this patient. She was isolating herself in the room by requesting the shades to be put down, the lights to be off, and the door to be closed. During my session with her, she actually drew herself on the boat alone, stating how much she missed her family and how the fact that she was in a hospital made her have a huge loss, as she was not able to spend the remaining time with her family. She shared that she lost her identity as a mom, as a wife, her independence, and how she needed to depend on others now. This made her feel very sad due to her losses. So she cried a lot during the session, and this really struck me when she cried, as she related to her losses as shown in this portrait. Interestingly, on contrary, I had another patient who was prepared emotionally. She knew the direction she would be taking. She had a clear and strong spiritual path and was clear on the path that she would journey on. Just like you see in this artwork, she has a bright personality and had the ability to negotiate her losses and shine through as she rowed her boat towards the light of faith as well. The second aspect under patient attributes is retaining personhood. We learned that patients actually rely on coping mechanisms like humor, which promotes feelings of relief. And humor is actually important to help enhance communication, preserve dignity, and exert personhood. And I quote, "Funny moments and jokes are seldom experienced in end of life." And she showed that these moments were important to keep her happy. I remember this patient, she was on nasal prongs and she was very breathless when she spoke. She couldn't move a lot because every time she exerted herself, it made her very breathless. But even she was so breathless, right? She would still talk and tell me jokes and even make me laugh. She explained that actually what she wanted, right, is for people to remember her for being jovial on her deathbed and not someone sad and crying. And to her, being able to joke and laugh is so important because this was who she was in terms of personality. And she also shared that if she could choose to smile or to be sad before dying, she would choose to smile because it's actually less tiring to smile than to cry. So, she shared a lot with me. The next thing that we learned is resilience is a very important aspect for a patient's attribute as well. We learned that patients overcoming the isolating experience of dying by drawing from life experiences to self-soothe is important. And childhood memories were, interestingly, often familiar sources of comfort. And I quote, he shared that childhood was a relaxing and happy part of life. He remembered his atap house in the kampong, where children were running around. So my patient described his kampong to be the best place in his life. His kampong was in Malaysia. He had very loving parents. He used to run around the kampong playing, and his parents would nag at him, hey, don't run too far away. He described, the cats were all climbing on the tree, and his parents were actually farmers, so they took care of cows and different livestock for a living. So he told me, girl, last time really got no stress, and just by remembering the kampong, I actually feel better from my pain. So there was a lot of reminiscence in this aspect. Another patient of mine spoke about how life experiences shaped her strengths in overcoming difficulties that she was going through. This beautiful rose in this artwork actually showcased her blossoming, despite of all the challenges that she's facing due to the life experiences that she has. So for the fourth aspect of patient attribute, we talk about satisfying relationships and connections. So even transient and transactional relationships are fundamental to feel connected. So let's say in the institution, how the environment is, it can feel socially isolating by its design, and it actually can affect a patient's health as well. And I quote, he had been so bored, which made him feel as though he could go mentally crazy. There was no television in his room, and he had no visitors who came by during the day. So if you look at this image here, right, this was actually an old designed palliative care room in an institution years ago. And my patient spoke about how, right, he would rather be placed outside with his other patients, as at least he still can see people move around. He said that even when the doctors, nurses, and therapists came to see him, right, it was not enough to make him feel better because the time that he was stuck in the room alone, right, was actually more than having any interactions.
I took this picture as I sat with the dying patient under the No One Dies Alone intervention. As the patient was drawing her last breaths, I thought to myself, I never thought I'd say this, but this was the best toward view. Few get to sight this sight from their beds when their time on earth is due. Some cry and whine and whimper, some fade into the night. Others may choose to breathe their last, cradled by their wives. Winter's cruel to the silvers, though in spring too they fade, by God's will or by happenstance, an end to last of days.
If you look at the artwork on the left, it's actually a lino cut carving of a mother bird and a baby bird, showcasing some patients that I have seen thinking about their mother's love, especially when they have a lot of pain at the end of life. So one particular patient of mine in his 40s and his mother in his 70s, my patient was in a lot of pain. He was saying, Ibu, Ibu, sayang, sayang, sakit, sakit. He kept saying this, and his mother would massage him, pet him to feel better. And more often, he felt better with his mother's comfort. On the right image, you see this artwork showcasing the love between the husband and wife. The patient depended on his wife for emotional support, and so did his wife. Both of them were grieving, and they were both supporting each other with the different challenges and the different types of grief that they were going through. So these few examples showcase how important it is to have connection. Okay, next I'll move on to clinical care. For the first aspect, holistic clinical competencies, we talk about dreams and cultural symbolisms. there were often vehicles for patients to communicate psychological distress, especially when stigma and cultural differences or language barriers make these expressions difficult. And cultural competence in clinicians is very important to identify these psychological needs. Otherwise, this is often gone unnoticed.
She was bothered by unpleasant dreams. She was walking alone when she heard a voice calling her name. In Vietnamese beliefs, hearing one's name being called out in the dream is a bad omen. Her intrusive dreams informed us that she was still affected by how cancer had threatened her life. I recall this patient seen in the clinic. She was a survivor, breast cancer in remission. And whenever she was asked, "How are you doing?" by the psychiatrist, this was how she answered. Had we not understood the cultural significance of what she was telling us, we would not have learned from this patient that patients who have survived cancer can still experience psychological distress. Ama oi zon oka. Ama piang oi. Mother is sick. Mother wants to return home. This is a tribute to a Hakka patient on her deathbed.
So the second aspect for the clinical care would be the capacity for reflective practice. So we learned that opportunities to revisit and reflect upon these difficult emotions actually allow clinicians to develop insight and find renewed purpose in where they are working at. And us as first authors, we actually recognize that, just taking part in this study is a form of metacognitive exercise for us.
I had lost a patient to suicide on a Wednesday, and I lost another patient that same week on a Friday. That Friday evening, I went home at 7:30. When I went home, I went straight to the toilet, turned on the shower, squatted, and began to cry. I thought to myself, sometimes I lose patience and I wonder if it was my fault. Did I not do enough? Was there something I didn't see? Was I incompetent? Should the blame be on me? Should my heart feel this broken? Must my pride be so sore? Why do I have this feeling I could have done more?
We also learned that another form of clinician self-care was gaining personal closure with demised patients through self-reflection and tribute giving. And these activities actually create a space for clinicians to terminate care appropriately and facilitate self-debrief and enhance a sense of role fulfillment. And I quote, "My response art is my tribute to the patient. It was uncertain how his funeral rites would be held. This image was my tribute and my closure. I hope that wherever he is, he will be in a comfortable place." So this patient of mine was actually a very impactful one. I remember the palliative care team activated me urgently because they felt that he really needed emotional support through art therapy. And I still remember, this patient, he is a big, bulky uncle, don't wear his outer shirt, very friendly, and also tell me, come, Mei, have a seat, So we had a good session together. He was very open to me. However, he passed away after a few hours, and this was very shocking to the nurses, the doctors, and myself. And due to this shock, right, I found the need to have the closure for myself. And in the end, I drew this image. Actually, this is my personal tribute to him as part of my closure. This artwork was another tribute that I did for my patient. If you remember the case that I shared earlier, the patient who was telling me about his kampong days and reminiscence, he passed away. And as part of my closure, I actually drew him back with his loved ones reunited and back to his beloved kampong and titling it as Complete. We also learned that clinicians who practice in a culture of collaboration, advocacy for clinician well-being will feel more empowered in providing better care for the patients with psychological issues.
Peer supervision and regular debriefing were really helpful for us as we consolidated our findings of this patient who had cancer and schizophrenia and was admitted under the Mental Health Act in Victoria, where we discussed limitations and challenges and addressed difficult emotions. This patient really taught us a lot about understanding how persons with mental illness also can experience psychological distress, though in their unique way when they're experiencing a life-limiting illness.
Okay, so the third aspect is integrated care and support systems. So we understand and we learn that good psychological health results from a robust and well-integrated care system that connects patients, family, care providers, and support structures. And I quote, "Without the connection, a flower would just be a flower. When created into a raft, it is more beautiful and stronger." The medical team must connect with the different allied health professionals and nurses to form an alliance and ensure that the patient has good physical and psychological care. I'm very fortunate to have met and be connected with the palliative care team, who included me and the other allied health professionals during our department meeting. We are able to plan, offer suggestions, and come up with holistic plans for our patients' physical and psychological well-being. We also learned that interprofessional collaboration between palliative and psychological health teams facilitates awareness of the psychological dimensions of dying and recognition of psychopathology. And this understanding allows access to psychological support for our patients as well.
Palliative care physicians can accurately pick up psychological symptoms, though they may not possess the expertise to evaluate them. This highlights the role of the psycho-oncology specialist in performing joint assessments with the palliative team in developing a holistic view of the patient. I often enjoyed, both in my time in Melbourne as well as Singapore, whenever we had opportunities to take care of patients together, both the mental health team as well as the palliative care teams. I find this kind of collaboration more meaningful and fruitful, and it delivers better care outcomes for patients. Now, Roxanne and I have taken all of us today through our journey, writing up our experiences with our patients over a half-year period across the sea between Singapore and Melbourne, and how we have run a thematic analysis to produce narratives, themes, and stories to inform the original questions that we have asked. What did our experience in palliative care teach us about the needs of patients who require psychological care? And the key findings that we have elicited in our work is that, firstly, when it comes to patient attributes, effective navigation of the dying process enhances the perception of psychological well-being in patients, as well as the caregivers and clinicians who take care of them. We find that key aspects of this effective navigation includes the ability to navigate relationships, asserting and maintaining their personhood, and the ability to demonstrate resilience. Secondly, on the sub-theme of clinical care, this we already know. Holistic and reflective practices are essential. But how do we integrate holistic and reflective practices into our care systems, into our care model? That indeed is the holy grail that we should be adopting in patient care. We also found out that there are humanistic elements when it comes to the delivery of psychological health in palliative care settings. For example, cultural understanding. Cultural competence is really important in understanding what patients are telling us, what their health beliefs are, and what their value systems are. We have given you stories and examples of how the cultural understanding and sometimes even cultural identification of clinicians can help us understand the symbolisms that express grief and distress. And therefore comes the question, do we need to teach cultural competence in clinicians? How do you even teach cultural competence in clinicians? And of course, lastly, there is an increasing focus on clinician well-being in healthcare settings in recent years. There's been a really active discourse. But how is this clinician well-being instituted, especially when in specialized care settings like palliative care? We found it in the process of journaling and using journaling to come up with a study. The process of walking through end to end has taught us that the process of journaling fosters resilience, and it forces us in an environment where we need to examine our thoughts, behaviors, and emotions, almost like looking at oneself through a third person perspective. And this third person perspective allows us to more critically examine how these behaviors affect or change our perceptions of care and what life-limiting illness experiences mean to the patient through our lens. So in conclusion, as a patient dies, elements of being human become increasingly important as patients approach death. And these are essential contributors to a sense of psychological well-being. Secondly, we found that the environment, including palliative care spaces and infrastructure, both physical and human infrastructure, need to promote a sense of intimacy, connectedness, and fostering of relationships. Thirdly, a similar focus is necessary for clinicians like us, who share the same space as patients in palliative care because their values, perceptions of psychological health, and well-being influence their provision of good psychological care. Therefore, it is important that we address clinician well-being, including burnout, with the relevant support infrastructure, provide spaces for emotional expression and processing, a webinar like this being one good example, and lastly, incorporate interdisciplinary collaboration and ethics consultations. I would like to invite all of us to have a broad glance of the remaining artworks. Of course, there are more, but we couldn't manage to share all of them today. But we have selected a few more for all of us to take a look at the artwork, most of them Roxanne's, that we have generated. And these are visual stories of our encounters with our patients. While we don't have time to talk through or take you through all of them today, we hope that this invites some curiosity, that you would look at them and wonder, I wonder what's the patient's story that informed this image today. So with that, Roxanne and I would like to thank you for your attention, listening to our little stories of our patients and patient encounters. We are glad to take any questions, and I believe that in a moment, our team will provide the slide and QR code for Slido, which is a platform which will allow you to submit your questions. And Rox and I will be more than glad to take any questions, reflections, or sharing that you may have relating to this study.
Yeah, that's right. Thanks so much, Phei and Roxanne, for your sharing. Could I then just ask for the slide that shows the QR code? Yeah, that's right. So for our webinar participants, please do join us at slido.com. Put in the code 1091972 that you see there, and you'll be able to type in your comments, your questions. Both Phei and Roxanne will be able to see it back end, and we will then field your questions from there. All right. Okay. Phei, as I was, well, actually, both Phei and Roxanne, as I was listening to your sharing, I was just thinking, for both of you, besides both of you work in the healthcare setting, and I think we do see a number of narrative medicine, narrative journaling pieces coming out of this care setting in particular. Besides palliative care settings, do you see visual journaling being important or being helpful to the clinicians in other types of care settings?
I think Roxanne is well placed to take this question.
Mm-hmm.
So Roxanne, over to you. I think you can tell us a lot of things about visual journaling.
Yeah, so I believe that any department can actually pick up visual journaling, and you'll be surprised that the artworks will come out very different. Because I also work in the psychiatry setting, my artworks, my response art is very different from how I would draw for my response art in palliative care setting. And when I look at my artworks that I churn out for my geriatric settings when I do response art is again very different. Yeah, so I believe that visual journaling, wherever you put them to the different aspect that you want to learn more and study more about it, go ahead, go for it. There is no right, no wrong. There's a common perspective that there is a need to make beautiful artworks. No, you don't. Response art is about creating it immediately after there's a reaction, a response that came up. For example, you saw a patient and you felt, wow, I feel very uncomfortable. I really need to let it out, but I don't know where to let it out. Some people, they do their other self-care, but you can take visual journaling as a way to let it out. So you make that artwork immediately, and you immediately journal down how you are feeling, the thoughts and what was happening, and then you process through that entire artwork and the emotions that went through as you have seen your patient. I hope I've answered the question.
Okay, thanks, Roxanne. Roxanne, I was just thinking, when you say immediately, right, because it's response art, does it mean, at the end of the day when you go back, how immediate would it need to be?
If you can do it immediately after seeing the patient, that's great. If you can't, the end of the day, if it sits with you and you're not sure what to draw immediately, that's fine. Because sometimes these feelings linger on for days. And maybe after that few days, you might want to also create a response into how you're feeling at that point of time.
Okay, thanks very much. Yeah, I do see a number of questions coming up on Slido. So, Wen-Pei, can you see them as well?
Yes, I do. I think there are a lot of questions coming in.
Okay. Can pick your favorite one and start.
Yeah, so let's manage the question. I think, first of all, thank you very much for the questions. I see them coming in, and as I speak, there are more. So I'll try to get them addressed to the best of our abilities. So the first question is, how long did it take for the team to complete the research? So this is an easy question, I think. I went for HMDP in July 2019. I proposed the project to Roxanne about a month later. Our journaling was between July, August to about end of December, early January. And we did some iterative journaling for up to 2 months after that. So it was approximately 6 months of data, about a year plus of thematic analysis and coding. And of course, Claire was episodically present in between. As I mentioned, Claire is our co-researcher as well as research mentor. She's a music therapist and researcher with University of Melbourne as well as St. Vincent's, Melbourne, Australia. And after that 1.5 years of coding and thematic analysis, and mind you, this was the time when circuit breaker was happening. So we were like on team, off team. So Roxanne and I, certain weeks we couldn't meet because we were segregated. Certain weeks we could. So it was also artificially delayed because of the pandemic. But after that, Zoom came into the picture. Then we met on Zoom. And then we wrote up the manuscript, which took about up to a year. And then we submitted to the first journal. We got rejected. And then we submitted to the second journal, which came back with major revision requests. And in fact, there were 2 major revision requests. And at the third attempt, we were accepted for publication. And we're really glad because palliative medicine is a highly regarded journal in palliative medicine. So we were really humbled by the acceptance, and we also learned a lot from the editors and the reviewers who gave us really constructive feedback on the paper. So we got published a few months ago. So you do the math. So I think end to end is about 5 years. The SRB didn't take very long, and I think that's a lead into the next question. So the next question, I'll read it for everyone's attention. As a nurse hoping to conduct a research study, I would like to ask how consent was obtained to collect these findings. So because practice wisdom and reflexive journaling is not really well known in Singapore, and I couldn't find any papers in the Southeast Asia or even Asia Pac region either, with the exception of Australia. So I asked my research office here in Woodlands, they didn't really have a lot of experience with qualitative research, let alone reflexive journaling as a form of data. So we wrote to DSRB before making the DSRB submission. And we asked, look, this is our research model. Do we need DSRB approval, or are you able to exempt us? Took a bit of to and fro because they asked us some questions for clarification, but they just asked us to submit DSRB submission on Rome anyway. So Roxanne and I were like a bit scared because we all know what the process is like. It's really rigorous. So, but after we made the submission, they actually exempted us quite quickly because there was a conversation beforehand. So our advice to budding researchers is that if you're adopting a methodology or a paradigm that is relatively novel, seek advice from your research officers first, or write into DSRB to get into a conversation with them to understand what the needs are before actually making the submission. You could actually elicit really good advice from there. Now, there are two questions I find particularly interesting, and I think Roxanne would be well placed to take this question. Roxanne, I want to draw your attention to the two questions at the bottom on Slido, which you and I have viewed to. Maybe we can address the first question. What other artwork do you encourage clients to do apart from paper and pencils?
This question feels more towards art therapy, but it's okay. I will just answer this question. Yes. So I think in Singapore we have this context that art. I mean, when we use art with our clients, we think it's just paper and pencil, but actually it can include a lot more things. It can include things like painting, clay making, even looking at creative arts videos, looking at the use of VR. There's just a lot of things that can be done other than just pen and pencil. So I hope I answered this question. In the art aspect, I think we have to open up our mind, and anything can be used for art as well, as long as it fits the client's needs. Back to you, Phei.
Thanks, Rox. There's also another question on I think there are two questions there. I think there's some relationship or running theme between them. I was curious, Roxanne, if you'd be keen to share with us whether you have elderly patients who fear talking about palliative matters or end of life, and how you engage them to open up. I direct this question to you because I remember in a conversation where you're engaging elderly people and elderly would say, I don't know how to draw. And you managed to slowly inch in and made the whole process seem less scary for them. And you said something along the lines of, can you draw a triangle? If you can draw a triangle, you can participate in art therapy. So why not you share more with us on that?
Yeah, I think most of the elderly patients, I have to say that at least 80% will reject me when they first see me. Yeah. So the approach that I take with them would be to really have a small conversation with them. Very simple things like, how are you feeling today? You know, and then asking, you know, are you having pain? And then I slowly inch in. Then I slowly inch in to introduce art making to them. And then I will start to use a lot of interesting things to, you know, get their attention, because some patients, they quite like to be entertained. And I'm quite good at entertaining them with the different art materials as well. And yes, to the question of whether elderly patients have the fear of talking about palliative care, yes, I think if you place anyone in that situation, I can say that almost everyone would be fearful to talk about palliative care, even if I'm in that situation as well. And how do we engage and open up? I think there's a lot. The person that would sit with the client would really need to have very good listening skills, a lot of empathy, and really to see what the client, what the patient needs. For example, if they say that, you know, I have a lot of undone matters, I need legacies, and that is where we would try to help the clients to, you know, achieve that as well. Yeah, but yes, it's hard for them to talk about palliative, and we definitely need to give them time. Yeah, back to you, Phei.
Well said, Rox. I would like to bring our attention to what personally is my favorite question here, and it's been upvoted as well. The first question on Slido, Roxanne, and I hope we can address this together. The question is that the reflections can be heavy at times. So how can we regulate these emotions? We can look for RO, reporting officer or supervisor, but the RO is human too, and they invariably might also be affected by this process. So maybe I can share what the process has been like for me, and Roxanne can chime in what it's like for her, especially in the capacity of an art therapist. So, so over the years, you say you have a subspecialty of interest, but sometimes I find the work finds you. And over the years, I found that I have gravitated towards end-of-life care and the care of psychological distress in clinician well-being. And after a while, I realized that the kind of work that I've chosen to do is actually quite heavy. And I realized at some point that I needed to proactively seek supervision rather than wait for something to happen before I reactively seek debrief. So what I started to do was to identify who my guardian angels were. You know, there's always that friend or colleague who is always more sensitive to whether you're doing well or otherwise. I identify who these people are, and I go to them and I tell them that sometimes I am not very good at recognizing that I'm not doing very well. Besides, people think I do this kind of thing, so I must be very good at taking care of myself. But that may not be the case all the time. If you recognize this, I want you to come and talk to me. I want you to be the trip line so that I know that I need to do something to ensure that my self-care is taken care of. So make sure that there are people around you who can recognize and provide some form of peer supervision. The second is, besides on an individual level, what can we do on a systems level to ensure that issues like clinician well-being, vicarious trauma, burnout is not systematically ingrained in healthcare teams and systems? So I think that systems like, for example, team debrief, team care sessions. My department, for example, will be introducing rejuvenation rounds in our department teaching, where every quarter of a year, as part of department teaching, a member of the team will do something that is related to team care. Doesn't matter what it is, we can, dish out a box of crayons and everybody draw on a piece of paper together, and we can talk about how work is difficult and all that, but that is part of team growth and we are able to do it together. And the teams I work with in Tan Tock Seng Department of Palliative Medicine and Dover Park Hospice have built in things like psychiatry rounds, angel rounds, psychosocial rounds, precisely with the intention of not just discussing patients, but also discussing the impact of patient care on clinicians. So clinicians get their airtime. And it is also during these sessions that you identify clinicians who are a bit more vulnerable. And then there's also on a macro system level, and in the past year or so, CWO's office have introduced things like mental health breaks, where if you are a second victim in a sentinel event, there's a recourse for you to take time off if you feel that you're psychologically distressed from the event. So interventions need to happen. You need to know how to take care of yourself, but the system also needs to build in support structures to ensure that that care happens. So that is my perspective from my journey. How about you, Roxanne, in your work as an AT?
Yeah. So for me, okay, I just share a case so that it's easier for everyone to understand. So I had a patient who had tracheostomy and very smelly wound around his tracheostomy. So he passed away very quickly and he cried so much during my session. He cried for 1 hour. And when I left the room, right, I could feel my body being very heavy. I could feel my head very heavy and I was very tired. If a normal person would have gone through this, they might not be able to pick up that this was actually transference. That means, like, whatever that the client was, expressing their emotions was actually placed and, onto the person who was listening. But for myself, because as an art therapist, we were trained to be very self-aware. So I could feel that, okay, you know what, I have to really do something about it. And no, I didn't do artwork. During the weekend, because the smell followed me, I could remember the smell, and I just had to get the smell out of my head. So I went to the nature, I went out with my family, I did nature walks, I ate what I like. And all these were small little self-care activities that have lined up for me over the years to keep me well as well. And on top of that, the palliative care setting that I'm in, every month we do have this rounds. It's called the remembrance rounds. So I actually spoke about this case with my team members, and we also did tribute giving, where we do a small artwork and we give tribute to those who pass away. So this was how we regulate and help our emotions as a team as well. Yeah, back to you, Phei.
Thanks, Roxanne. And I think we have time for one last question. I'm sorry if we didn't manage to answer all of them, but I'm saving the best for the last. And that's a question from my old boss, Aaron. Hi, Aaron. And Aaron's question is, he would like us to comment on the move from cultural awareness to cultural sensitivity to cultural humility and the training for cultural humility. I think that if I may have a go at it, Roxanne, I think this is where the intersection between reflexivity in qualitative research and reflective practice comes in, where the opportunity for reflection and the purpose-driven and intentional act of reflection is built into our learning. Because I think we think a lot about training and curriculum, and in fringe or medical humanities or healthcare humanities, we like to talk about, we need to encourage our residents to reflect more. We need to encourage our students to reflect more. Let's get them to write a journal. Okay, let's get them to journal. And your students will drag their feet to journal, right? Because some of them don't like it, some of them find it onerous, and some of them find it confronting. And we need to acknowledge all these difficulties and challenges, and not write off these difficulties as simply learners being lazy, or inadequate, or not being able to see the value of reflective practice. I think what is also important is, firstly, having teachers having the necessary skills to introduce a method of inquiry to invite that reflection so that they can appreciate the humanistic elements of their practice. So that is one aspect that I feel is important. The other is the thing about psychological safety, right? I think when it comes to reflection, I think reflection is really not possible if learners don't feel safe sharing about what are intimate thoughts and feelings. I think that is why whenever you ask learners to reflect, they tell you a lot about their thoughts. They don't readily tell you about how they feel. Because in our training, and we think healthcare is all about science, it is second nature to us to think a lot about the evidence. And we're often taught to mute our feelings because it might affect our objectivity. I think that mindset needs to change if we need to embrace cultural sensitivity and therefore cultural humility as part of holistic healthcare education. So that's my 2 cents on the question. I don't claim to be an expert in cultural competence, but I do feel very strongly about how cultural competence is really important in adding nuance to our practice in medicine and, of course, healthcare. Roxanne, what are your thoughts about this?
I think you've covered it all, Phei.
We're going to call it a day, Roxanne.
Yeah.
Yeah, thanks so much for that, Rox. So I think I'm doing a time check. It's 1:58 now. So I want to take this opportunity on behalf of the Humanity at the Heart of Healthcare seminar series team, Roxanne and myself. I want to thank you for sharing your lunchtime with us and giving us the opportunity to share our work with you. I'll hand the time back to Winnie.
Yep. All right. Thank you so much, Wen-Pei and Roxanne. Thank you especially to Wen-Pei for putting it in that pitch about, how do we structure the clinical learning environment? And really, that was one question that I really wanted to ask you, wearing your hat as an educator. When you spoke about, how it helped you, Wen-Pei and Roxanne, individually as clinicians, right, as people, seeing these patients and acknowledging the effect that it had on you. That was, I think, something that's important that we bring to our learners. I was also thinking about how do we then structure the learning environment so that our learners feel safe. And so I'm very glad, Wen-Pei, that you talked about the role of having mentors, role models, peers to watch out for us, role of psychological safety as well. So I think this really leaves me with very few questions, but very few questions that I will catch up with you later. Thank you both again, Wen-Pei and Roxanne, for bringing us through this very, very thought-provoking webinar. A lot of things to think about, whether you're an individual practitioner, whether you are also somebody who's looking to whether you can bring art therapy to your clients and to your patients, as well as for us educators as well, in thinking about how do we use this to care for our learners. Now, for those of us who are interested to read Wen-Pei and Roxanne's article, we will share the link to that in our Teams channel, so no worries about that. So some housekeeping matters for our participants. There's a QR code, and we'd like for you to use that to let us know what you thought about the webinar today, what you enjoyed about it, and to indicate your interest about future topics organized by Edu Research. Thank you very much, and hope to see all of you in the webinar. Thank you very much, Wen-Pei, Roxanne, and for all of you who have shared your lunchtime with us. Thank you.